we're going to be talking about symptom management and quality of life. And people often talk colloquially about whether or not the cure is worse than the disease. And I think that many of you who experienced side effects from effective treatments might have considered that question yourself. So it's a real honor to drill into this question of how can we feel as well as possible? How can we maximize the quality of our life, even as we are working to control the disease and cure the disease? So we'll have two brief talks and then a panel discussion to complete our session. So to lead us off, I want to introduce Lindsay Hampson, who is an associate professor in the Department of Urology and the chair of education, vice chair of education, and the residency director in urology, to speak with us first for a moment talking about managing lower urinary tract symptoms and sexual function symptoms. So thank you, Lindsay.
Thanks. It's great to be here and to see some faces in the audience that I know. It's really a pleasure to be able to talk about this topic, which I think is really important and sometimes can come as an afterthought. And really, I think the big thing to know is that there are people like me and others who can help with symptoms after treatment or during treatment. And so if you have symptoms, have friends, family, patients with symptoms, it's just really important to know that there are opportunities for improvement. And hopefully I'll talk a little bit today about some of those opportunities, but know that these are discussions that, that we can continue to have. So in terms of disclosures, really only related to some funding, which is actually quite relevant here. I do some NIH-sponsored research on how to help patients make decisions about urinary incontinence after prostate cancer treatment. So that's a big passion of mine. And today we're going to talk mainly about some urinary symptoms, mainly incontinence, and then about sexual dysfunction as well. So a lot of people, the first thing that we need to assess when somebody comes and it has urinary incontinence is really to talk about what type of incontinence they have. And there can be many different types of incontinence, and they really help to drive our treatment decisions. So it's really helpful, I think, to just think of this kind of broad overview of incontinence. So you can come and you can see a urologist in clinic because you have urinary leakage, but depending on what's causing it is really going to drive what options we have for treatment. So stress incontinence is something that we typically will see after treatment for prostate cancer, specifically prostatectomy. And that's really a problem where you've lost some muscle tone of the external sphincter. And so usually this presents as people who say that they have leakage when they're doing activities, coughing, lifting something heavy. Even if they have severe incontinence, it can be, they're fine when they're lying down at night in bed, but as soon as they get up or stand up from a chair, they're having leakage. Urge incontinence is different and treated differently. Urge is really related to the bladder muscle itself. And so when we think about urge incontinence, we're thinking about overactivity of that bladder muscle. And in the prostate cancer world, I think often we see this either when people have had really enlarged prostates over time, that this is something that develops over time. It's pretty insidious. And so sometimes people say, well, my prostate's gone. I don't have a big prostate anymore. But if you did have a big prostate for a long time, you could develop some overactivity of the bladder. Or we see it in relation to people who've had radiation treatment. Mixed incontinence is also, can happen. And that's really where you have both of these problems and they're treated differently. Overflow is a situation where you can't empty your bladder well. And often this is because you no longer have the sensation that your bladder is full. And so you're leaking because your bladder simply can't hold anymore and is kind of leaking that overflow. So, whenever I talk to people about incontinence, I always, tell people that even a small amount of leakage can be bothersome. And I think it's helpful to think about the fact that even a few drops of leakage, can be impactful to somebody's quality of life. And so when you're seeing, somebody in follow-up and they're saying, yeah, it's okay, I, have a little bit of leakage, but not much. even that small amount of leakage can really be impactful. And we've done studies here. In fact, Dr. Cooperberg did a study that looked at small amounts of leakage and how much they drive quality of life for people. So it's important to remember that, all leakage can be, bothersome and can be treated. So even if you just think, well, I only have a small amount, you could still be a candidate for treatment. There's lots of different workarounds for incontinence. And, some of you may know some of these, pads and diapers, and we can get into all kinds of discussions about what types of those, people use. There's something like the Afex system, which is up on the top left, which is like briefs that you can wear that help collect urine, condom catheters, which are challenging, but some people will use in certain situations. And I think the goal is to know about these products so that you can use them if you want them, but also know that there are also fixes, so it doesn't have to just be workarounds for leakage. Penile clamps are something that some people find really useful. These are literally giving you a device that constricts the urethra and prevents you from leaking. And there are lots of different devices that are available. We have one that we give out commonly in clinic for people to try that's called the Cunningham clamp, which is the second one down there. But you can go on Amazon and see all different ones. And I actually really like this. This is taken from Dr. Breyer, my partner's research, that shows like what patients really like about these, and it shows the cost of them, so you can kind of see the ups and the downsides. And I've even had patients who have made their own. So in terms of evaluation, again, we're really talking about getting a good history when people come in, and that means we want to understand what your story is. The biggest differentiator in my mind between understanding why someone's leaking, is it stress, is it urge, is it both, is really understanding when they're leaking and how they're leaking. And so those are questions about when the leakage occurs, when it doesn't occur, what things might cause the leakage to occur are really important. Some people only need that kind of information gathering to really understand what type of leakage they have and to give treatment options for it. And there are other people who will need further evaluation to look at things anatomically. Sometimes that can involve urinating and then getting an ultrasound of the bladder to see how well you're emptying. Sometimes it can mean using a camera called a cystoscope, which is about the size of a small catheter, probably smaller than the one that you had when you had a prostatectomy, if you had one, that goes in the urethra and actually can look on the inside at the bladder, at the prostate, at the sphincter. And then I would say more rarely, sometimes urodynamics can be useful. And that's really a study of the bladder function itself, which involves placing a very tiny catheter into the urethra and bladder, filling up the bladder, and then understanding how the bladder functions. So all of these things can be useful adjuncts. In terms of urge-related incontinence, as I said before, this is really incontinence that happens because of a bladder muscle overactivity. And the typical symptoms that we hear when people have urge incontinence are, I had to, as soon as I knew that I needed to urinate, I had to rush to the bathroom. I couldn't get there in time before leaking. As soon as I heard water turned on, I leaked because I couldn't hold it. And a lot of people will say, well, I urinate and then I feel only 10 minutes later that I have to urinate again, even though not much else is coming out. So these are very typical urge symptoms. There are some bladder irritants that you can kind of play around with to see if it helps. And there are some people who find great improvement by eliminating these bladder irritants from their diet. I always tell people you still have to live your life though. So take it with a grain of salt. There are medications, and I would say emerging evidence is really showing that this newer class of medications called beta-3 agonists is really helpful. Anticholinergics were used in the past a lot to treat these symptoms, but had a lot of side effects. And the good news is that these new medications have many fewer, if any, side effects and can be very effective. So that's great news, and kind of a newer treatment in the last 5 years. And then there are other treatments too. So there are more kind of a diversity of other options, and you can talk with a urologist to decide if these might be applicable to you. They include posterior tibial nerve stimulation, injecting Botox into the bladder, the same Botox that you get in the forehead, but you put it in the bladder, and something like neurostimulation, which can control the bladder muscle, nerves that control the bladder muscles. In terms of incontinence after prostatectomy, this typically when we see stress-related leakage, and that's activity-related leakage, it's after somebody's had their prostate removed surgically. And we know, looking at large data sets like Medicare that look at a big swath of our population, that about 30% of men will have leakage afterwards. We are very lucky here at UCSF to have excellent prostate cancer surgeons, and so our rates of incontinence here are quite low. But despite that, we know that there are many people who will have leakage as a result of prostatectomy. And we know there are some factors that contribute to this. Age, if you're older at the time of undergoing prostatectomy, you're more likely to have leakage afterwards. If you have a larger prostate, your sphincter length, which is just anatomically kind of what you were born with. And if you've had radiation, that's probably the biggest impact in terms of your continence. We know that you can get improvement up to 2 years out. We have good UCSF data that show that, although I will say that there's very few people who really get improvement after 1 year. So we typically will tell people that there's this kind of curve during the first year. You'll see some improvement over time, and you will reach a plateau at some point. And some people hit that plateau at 3 months, some at 6 months, some at a year. Very few will continue to improve and hit their plateau after a year. So if you're dealing with leakage, yes, you're going to see improvement until a time, but when it plateaus, if that leakage is bothersome, then there are options for treatment if that's something that's interest to you. A lot of people ask about Kegel exercises, and this is something that we really emphasize ahead of time and after prostate removal surgery. And really, pelvic muscle exercises like Kegels are designed to improve your pelvic floor. So your pelvic floor is a series of muscles like a hammock, and they support your bladder, your prostate, and your urethra. And your external sphincter is kind of part of that muscle complex. And if you can learn how to activate that muscle complex, you can help prevent leakage. Kegel exercises are best if they're held for a period of time. So if you do a Kegel exercise, you want to try to hold that contraction to strengthen it, and also repetition. So we know that if you do repetitions, just like if you were lifting weights in the gym, you're going to help to improve those muscles. There's a lot of different Kegel resources, and I think at UCSF we give patients some internal resources. A nice one also on YouTube is Michelle Kenway. I have no relation to her or personal interaction with her at all, but I just think she teaches it in a really good way. And she's from New Zealand, so she has a really nice accent too. So I've heard that a lot of people who like those. Pelvic floor PT, how is that different than Kegels? Pelvic floor PT is really working with a pelvic floor physical therapist who's trained to administer pelvic floor therapy. They can often incorporate things like biofeedback so that you make sure you're actually doing the Kegel exercise correctly. So it can be very useful to meet with somebody to really guide your work in pelvic floor rehab in the beginning, especially. And I will say just one comment on Kegels. We know from data that Kegels can help improve your time to continence. That means after your prostate removal surgery, if you do Kegels, we've actually shown that it improves your getting continent faster. But if you look at the long term, it actually does not change whether you're going to be continent or not in the long run. In terms of surgical treatments, this is a lot of what we do here at UCSF, and there's lots of different options. Everybody asks about urethral bulking because this is something that's done a lot in women, and this is where you inject a substance at the bladder neck to try to coapt the bladder neck and prevent leakage. Unfortunately, there's really no data that it works in men, specifically after prostate cancer surgery. And so although we've tried it, so far we haven't found a good bulking agent that works. There are some adjustable devices that are relatively new on the market. I think we're accumulating data to understand how well those work compared to our kind of tried and true treatments. So I would say for now, we're still kind of feeling those out from centers that are trialing them. And then the two workhorses and mainstays that have been around for a long time are the male sling and the artificial sphincter. And I think I have just a slide on each. I'm not going to really go into the details, but just to give you an overview, a sling is a piece of mesh that's put under the urethra, and it basically lifts the urethra and helps provide support to the sphincter. So this is really nice for men with mild to moderate leakage. You just get to urinate like you normally do after the sling is put in, which is really nice. really high success rates in the well-selected population and very high satisfaction. Again, if you're putting it in patients that are well-selected. If you've had radiation, unfortunately, our success rates are much lower with the sling. So that's something to keep in mind. The other workhorse, and I would say what's probably the gold standard for incontinence treatment, is something called an artificial urinary sphincter. And this is a device that gets put in. So because your external sphincter muscle that isn't working as well anymore, this is literally an external sphincter that we get to put in. It has a cuff that's fluid filled. It wraps around the urethra to close it off. And this is all a hydraulic device. So there's no electronics associated with it. It's really nice because it can get pretty much anyone dry or nearly dry. So no matter how much leakage you have, no matter if you've had radiation, this can be very effective. There are definite downsides, and that's always something that we talk to with people, because often when you put a device like this in, we know that you're probably going to end up needing to have a surgery at some point to fix it or replace it or remove it because of different reasons and then put it back in again. I will say that when we do come across these situations where they stop working or we have to remove them, the question from people always is, when can I get it put back in? Because people like it so much and it's such an impactful way to change your quality of life. So really high success and satisfaction rates. And I put this in, this is from some of the research that we've done, just looking at, who chooses treatment for incontinence. And I think this is important just to say that, often people worry about, they've already had a surgery which has caused incontinence. Why do I want to go through another surgery which has potential for complications? And really, there's very few people who undergo incontinence surgery who are unhappy afterwards. We really see very high satisfaction. And oftentimes people are begging me to say, hey, if you have other patients who are considering this, please let me know. I'm happy to talk to them because it's been such a game changer. I think in the end, choice of whether to treat and how to treat incontinence is a really personal choice. And that's why we're in this quality of life kind of session, thinking about how to make informed decisions. It's a shared decision that you're going to have with the urologist. And it's important to think about what's important to you as the patient. What are your goals? What are you trying to optimize for? And not everyone is going to make the same decision. And there are some people, even in the same situation with the same leakage and the same parameters and the same characteristics, that are going to make different decisions. And that's because they're taking into account what's important for them. And I think that's really critical. So this is a chance whenever I counsel people in my clinic about incontinence treatment, this is a chance that I get to learn a little bit about them and what their goals are, because that's really central to making these choices. Okay, so switching gears to erectile dysfunction. This is very obviously widespread in the United States. I'm sure we've all, heard and thought about erectile dysfunction on the, commercials or otherwise. Prostate cancer treatment is not the only thing that causes erectile dysfunction. So often we see medical conditions like diabetes or vascular disease or heart disease that contribute. But certainly surgery and radiation for prostate cancer can also have an impact. And this, I included this is from Dr. John Lindsay, who's one of the erectile dysfunction specialists at UCSF in our department. This is kind of a new pathway that we're implementing here. Dr. Lindsay came back to us at UCSF after doing some fellowship training in infertility and andrology and really thinking a lot about erectile dysfunction. I think it's brought some energy to the concept of kind of rehab around prostate cancer treatment and erections. What can we do before prostate cancer surgery? What can we do afterwards to optimize erectile function? So this is kind of a peek at the type of pathway that's being implemented here at UCSF. And really it's meant to ensure that patients are plugged in even before they undergo surgery to understand to even start medications that might help their recovery and know what their options are both before and afterwards. So I'll run through just briefly some of the medications that we use to treat erectile dysfunction. I'm sure you've heard of oral medications, the little blue pill and others. This is something that's very effective. It works in response to sexual stimulation. So usually we recommend to patients to take it about an hour ahead of time. some of these medications need to be taken on an empty stomach to be more effective. And they usually work for about 4 hours. Some of them, like Cialis, have actually a longer half-life, and so they may actually work for a longer period of time. And really, they're meant to be taken not more than once a day. They can have side effects, and so we think about those, especially when we're thinking about cautions with other medications. These medications, unfortunately, aren't always covered by insurance and can be expensive. And so I put 2 options up there. GoodRx and Amazon Pharmacy actually often have cheaper ways to get these. So GoodRx has coupons that you can take to pharmacies, and that can be a very useful way to get these at a more kind of better cost. Side effects include headaches, flushing, stuffy nose, upset stomach, and dizziness. I'm sure you've all heard the warning about prolonged erections as well. And if you're on nitrates, which are drugs that commonly people may take for heart disease, if they have chest pain, they take a nitrate, you have to be really careful because both the nitrates and these medications can lower blood pressure. A vacuum device is a non-medication treatment that a lot of people find useful. It's really nice because it's very cost effective and really anyone can use it. It's basically a vacuum that you put over the penis, and either mechanically or with a pump, you can basically evacuate the air that's in this device, and it causes an erection, brings blood into the penis and causes an erection. And then usually there's kind of a constriction band that's at the base of the penis, and this helps maintain the erection. So there are some side effects that are listed there, but there are some people who really like this option because they don't want to take medications, and this is really cost effective. Penile injection is another option, and this is something that we teach patients in clinic to do. So these are injectable agents that can help stimulate an erection. The nice thing about injecting them is that you can give higher doses than you could take by mouth. So often these are similar medications that you might be taking by mouth, but they're in a higher concentration that are delivered by injection. And I can tell you, no one ever wants to put an injection in their penis. I get it. But I will say that for people who this works for, they find that it's actually very easy. You know, we teach you how to do this in clinic, and it can be quite effective. And there's a lot of people who, you know, are really like this method. In terms of surgery, there are penile implants as well. And these have been on the market for a long time. And there's a few different companies who make them. There's a few different types of implants. High satisfaction rates from people who pursue these. And often these are people who have tried the other routes that I've already mentioned and really haven't gotten success. And so they end up here talking about penile implants. But there's semi-rigid as well as inflatable devices. And so there's kind of up and down sides of both of those. The semi-rigid basically maintain their rigidity all the time, but you can kind of fold them down. The inflatable ones, you basically have a pump with fluid in it, and you can pump the device up to give the erection. And just here to show you, you know, really high satisfaction rates for people who are choosing these options, both from patients and from partners. And then lastly, just want to say, you know, we're here to help. We have a big team of people at UCSF who both concentrate on helping people kind of post-cancer treatment and pre-cancer treatment with these issues, but we're also really passionate about it. We all do research on it. We all speak on it all the time. So this is something that we really care a lot about. And so I just put some pictures up of who we are and what types of conditions we treat, so that if you ever want to see someone or send a friend in the future, we're always happy to see people. And I think that's my last slide. Oh yeah, these are my kids, because I got to throw them in, you know, any talk I give, got to throw those in. I have an 8 and a 6-year-old. So thanks, and I'll hand it back to you, Mike.
Thanks so much, Lindsay. Fantastic to really be focused on quality of life, which as soon as you get back to them, I'm sure your life will be better tonight. So thank you very much. I'm going to let you know that I'm a palliative care physician. I am not a urologist or an oncologist or a radiation oncologist, but it is my pleasure for the last many years to work with the rest of the folks that you've been seeing today, and really my honor to talk about androgen deprivation and how we mediate the effects of androgen deprivation, how we manage the toxicity. So I think about the adverse effects of androgen deprivation and treatment as including the side effects of the medicine itself, the possibility that the medicine may create increased risks for other diseases, or it may actually result in the development of other diseases. So we'll be talking about all of those. And there's three main adverse effects that I want to discuss today. One is cardiovascular effects. This is, for some, a life or death issue. Heart disease is the #1 cause of death in the United States. Yeah, it is not cancer. It is not COVID. It is heart disease. So heart disease is a serious issue. We can think about heart disease being mediated in the context of prostate cancer treatment through weight gain that we sometimes see, changes in lipids or your cholesterol, and worsening insulin resistance, which is the mechanism for diabetes. The amount of heart disease that develops in the context of androgen deprivation treatment is not totally clear, not totally precise, but perhaps around 20% of excess cardiac morbidity associated with androgen deprivation. Now, importantly, that's not been shown in all studies, so there's still more work to be done here. But suffice it to say, for most men, the risk could be significant and something to pay attention to, and certainly to be thinking about and monitoring. The effects of cardiovascular risk could be mediated through hypertension, show up as hypertension, as heart attacks, as fatal arrhythmias, as stroke. So much so, this is such a common issue in oncology these days that there is a subspecialty called cardiac oncology, that you have specialists who are cardiologists with really advanced and particular knowledge around dealing with cardiac risk factors for people being treated for cancer. The second big risk is hormonal. We've heard some of this already today. It includes osteoporosis, decreased bone density, loss of muscle mass, causing weakness, breast enlargement, which is quite common and can be associated with pain, and hot flashes, which is very common. Almost 30% of men might report hot flashes as the #1 worst symptom that they've experienced as a result of androgen deprivation. The third and important group of side effects, of adverse effects that I wanted to talk about are, I would label under the category of vitality. I hear this very frequently from men who talk about not just feeling the same, experiencing a loss of vitality, a word that I often hear. And this could include fatigue, very commonly the #1 complaint that people report in the context of their cancers. It can result in, androgen deprivation can result in sleep disturbance, low libido, loss of interest in sex. So this is different than erectile function. This is loss of interest in it, desire for sex. So much so that approximately 70% of men on androgen deprivation report that they've stopped having sex. We've also heard a little bit today about the potential for loss of size, decreased size of the penis and the testes. And then importantly, and this is something that some men traditionally have had difficulty even thinking about or talking about or admitting, which is the risk for increased emotionality. That's when you're crying because of a commercial that you saw on TV, something you never have done before, but all of a sudden you find yourself tearing up around a Kleenex commercial or something like that. Yeah. And then depression, which is a real disease that many in this room likely have experienced, regardless of whether or not you've been on androgen deprivation. It is a common experience for people and increased risk in the context of androgen deprivation. So we heard right at the very beginning of the day from Eric Small about weighing the different strategies for dealing with this. So if androgen deprivation is causing side effects, you can try and take less androgen deprivation therapy, and that might be appropriate. And you've heard throughout the day all sorts of research really aimed at trying to minimize harmful treatments, difficult, burdensome treatments to maximize benefits. But if androgen deprivation is going to be part of your regimen, the other alternative, the other strategy is to really think about how to mitigate the side effects. And that's what we're going to be talking about for the next couple of minutes. So management occurs in sort of two flavors. One is medicines, which I'm going to get to in just a moment. That's what I do a lot of, prescribe a lot of, and like to talk about, but I'm going to really be focusing in on something that's super important, which is behavioral interventions. And the reason that these are so important is because they are safe, something that I cannot claim for every medication that I might prescribe. They all have risk. So these are safe and they are very effective. And we're going to go into cognitive behavioral therapy and physical activity as interventions, but I just wanted to show you this chart that shows that there are a few things that can have lots of different effects. So lots of benefits from one intervention. So let's talk about physical activity. I know you heard some about that already. And if I could encourage all of us to do one thing in our lives, prostate cancer or not, it would be to exercise more. Motion is lotion. Exercise has been proven so helpful for so many things. And in fact, in the context of androgen deprivation side effects, physical activity has been shown to be effective for fatigue. The best intervention we have for fatigue, for sexual function, for overall quality of life, for metabolic syndrome and cardiovascular fitness, incontinence, bone health, and muscle strength, right? So kind of good for what ails you. So exercise, exercise, exercise. We talk about 150 minutes per week, so about 20, 21, 22 minutes a day. Yeah, so not that much. Once you get yourself to exercise, most people find some satisfaction with that and then can increase the amount of time that they're doing it. So it's really about sort of just getting it done, just starting it, yeah. So we want aerobic exercise. We want you to be breathing a little bit extra hard. And we want to think about resistance and weightlifting. We just heard about how exercise, Kegels, other kinds of exercise require the effort, the work against weight. Yeah, so both are important, resistance training as well as aerobic exercise. The second big behavioral intervention for androgen deprivation related side effects is cognitive behavioral therapy. Again, sort of a multimodal, a multi-effect from CBT, commonly the acronym for cognitive behavioral therapy, improving fatigue, depression, sleep, possibly also for the side effects of hot flashes and sexual health. So CBT stems from the idea that we get emotions because of things, we have emotional reactions to things, and then there are the complexities of what we think about our feelings, but what our thoughts are about our feelings, and then what we do, our behaviors. So it's the idea that you start off with an emotion, and then there are responses that have to do with how you think about it. Yeah. So those interrelationships happen as well, so that we can see that behavior can change our thinking and our emotions, and our thoughts can create feelings as well. So there's this very, very interesting, profound interrelationship between thoughts, our behaviors, as well as our emotions, and they can go back and forth. And so cognitive behavioral therapy is a form of talk therapy that helps get control of these relationships and sort of correct where there's errors in that process, in those interrelationships, that can help you do better. Meaning, if you are feeling fear, but that fear is causing you not to exercise, can we change the thought about your emotion, about your fear, so that you can feel good about exercise and get the exercise done that will help with your symptoms? So the thing about CBT that's really powerful is that it's short-term, that it's very goal-oriented, and as a result, it's covered by insurance. Yeah, but it's hard. It takes a lot of work. Like most good things, to see the effect, you're gonna have to put in some of the energy. And so CBT is famous for giving you homework. So you'll meet with a therapist, talk about these things, and then you'll have to work. You'll have to practice. You'll have to develop your skills so that you can overcome some of these side effects. Finding a therapist who does CBT can be hard. You can go to psychologytoday.com and enter your zip code and your insurance information, and they'll help you find someone. And we also have good data that doing CBT over telemedicine, meaning over Zoom or a video visit, can be effective as well. So again, my push is really to think about exercise, to think about CBT. There are also lots of medicines. There's lots of medicines you can try, and that can be very effective as well. So Terry Friedlander talked about bone health, and we talked about sort of the diagnosis with the DIXA scan, and he talked about the treatment with various medications. So I'm going to skip through there and suffice to say this is super, super important, and that we have really good treatments. And avoiding bone fracture due to thinning bones is really, really important. So let's go on to other things that have medicines that can help. First and foremost, I wanted to talk about depression. Depression is something that we have medicines that can be helpful, but the combination of talk therapy and medication is probably the most effective of all the interventions that you can think of. So when we think about medicine interventions for depression, we're talking about antidepressants, sort of the classic serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors, the SSRIs and SNRIs. Hot flashes. Again, behavior is key here. Lifestyle interventions can be very, very important. Acupuncture may even be effective, but you can think about some other things. So first on the list, as it turns out, happen to be antidepressants. So you can get a double benefit from your antidepressant potentially. Then venlafaxine, paroxetine are two that have been shown in trials to be effective, but probably it's a class effect across the SSRIs and SNRIs. Gabapentin is a medicine that can help for pain. It was originally developed for seizures, but we almost use it exclusively these days for pain management and for the control of hot flashes. So another medicine that you can think of. Oxybutynin, a medicine that can help with incontinence, another medicine that can be useful. New on the block is Feoza, which has been developed for women with hot flashes in the setting of breast cancer treatment. It hasn't really been studied well in men. So if you see an opportunity to be part of a clinical trial for Feoza, give it a try, because Feoza can be super, super effective. And then we heard very early in the day about estrogen as being effective, topical estrogen in particular, so that's on the list as well. Importantly, cardiovascular risk. One of the main points I want to make about cardiovascular risk is that you should be thinking about assessing cardiovascular risk early, essentially within a few months of starting androgen deprivation treatment, because we can see some of the effects on cardiovascular risk factors affecting men within just 3 to 6 months of starting androgen deprivation. So we can think about controlling hypertension with antihypertensive medicines. We can think about controlling cholesterol with anti-cholesterol medicines, Lipitor as the classic one. Yeah, aspirin as a prophylactic medicine may be indicated. And then there's interventional cardiology with stents and other things that cardiologists may do. So it may be that if you have no cardiovascular disease, doing monitoring, talking about this with your oncologist, typically your primary care physician may be sufficient. If you already have cardiovascular disease, which many people will, really, really being in coordination with your cardiologist to pay attention to rising risk factors for cardiovascular disease is important. Fatigue is, as I said, a symptom that is best treated with exercise, and I get it. You're tired, you may not want to get up and get out and go do exercise, but it's really important to do. We also have some medicines that may make sense for you. A stimulant medicine called methylphenidate, some people have used, or whose kids have used it for attention deficit disorder with a medicine that's a methylphenidate called Ritalin, so that can be useful. And again, another plug for antidepressants for those of us who are dealing with depression. There are some antidepressants that are activating that might be useful for fatigue. And then finally, sleep, improving sleep through various behavioral strategies. CBTI, cognitive behavioral therapy for insomnia, is probably the most effective and useful in the long term. And then melatonin may be useful as well. My take-home point, though, is all of this has to be determined and discussed with you, among you, your loved ones and partners who may be involved, and with your physicians and clinical teams. So that's your oncologist, your radiation oncologist, your surgeons, and folks like me if you're engaged with palliative care, to try and figure out how to match your goals with the right treatments, the right interventions that might help you achieve those goals. This is a difficult decision. It's a complex decision that affects so many parts of your life. So none of us have the single expertise to make these decisions ideally. We as patients are expert in ourselves, but there are clinicians that are expert in medicines, that are expert in procedures that can really help sort out these decisions. And I would point out that these decisions are influenced by so many things, including your prognosis, how long you expect to be living, what other diseases you're dealing with, and the prognosis of those diseases. And then ultimately, to remember that your preferences are likely to change over time. The decisions you might have made when you were 20 are not the same decisions you might make when you're 40 or 60 or 80 or 100. Yeah. So you learn over time. You learn what matters to you and what doesn't matter to you. What matters to you and doesn't matter to you changes over time. Yeah. And your experience of side effects may really change things. I have a lot of people who tell me, if I develop X, Y, or Z symptom, I'm going to stop treatment because I couldn't stand to have X, Y, or Z symptom. And then when they develop that symptom, perhaps later on, they say to me, you know what? It's not as bad as I thought it was. I can live with that because there are other things that are going on in my life that matter to me. So really, really just another plug for shared decision-making to really, really focus on what matters to you currently and how you want to weigh the benefits and the burdens of various treatment decisions. So I'm going to stop there. Thank everyone for your attention. We've got one last panel for some Q&A. And so thank you very much. Yeah.